Hi, my name's Sierra Donnell. I'm one of the pediatric residents. Lisa and I have made these slides and videos to try and make your first days on the Peds clerkship go a little bit smoother. We're really excited for you to join us. We hope you have a lot of fun and you learn a lot. So I just want to start off by going through the structure of how these slides are set up. My sections are going to be over the NICU and GCN. So my slides will be first, followed by the slides Elisa will cover in a separate video. And then we're wrapping up with just our general tips, resources for both in real life when you're taking care of kids, and then also for shelf prep. And then finally ending with some key points that we'd like you to leave with. So beginning with the NICU or neonatal intensive care unit, I want to start off with just an orientation slide. You'll typically arrive around 7 a.m., but I would confirm that prior to your first day because sometimes these start times can change. You'll touch base with the senior resident or the nurse practitioner if you're on an NP team to receive your patient assignments. And generally, we will just start you off with one patient. And I know sometimes when I've been in the NICU, we even just have medical students sort of just watch rounds on day one. They may follow along a baby, but not be responsible for presenting that baby on rounds because rounding in the NICU can be very different. So know that we know that, and it's okay to maybe feel a little overwhelmed in the NICU. It's all very different. So the way our NICU is structured, there are 3 teams. 2 of those teams involve residents, A and B. The B team involves a nurse practitioner as well as a resident, and then the final team is nurse practitioner only. So there's the 3 teams that take care of the 3 different pods generally. When you first arrive at the NICU, you'll see that there are some hand washing stations outside of each of the 3 pods. So in the morning prior to going back to the workroom, I would just stop at one of those pods and wash your hands, use the nail picks that are on the counter, and then wrap up with using that special hand sanitizer that's on the wall. And that hand sanitizer is just motion activated. And this is just important for all NICUs. This is sort of routine infection control. So try to remember to do that, especially before you examine any of your babies. While you're in the NICU, you will be going to deliveries, hopefully. And when you go to a delivery, you either need to have on those blue surgical scrubs. And if you either have on business professional or different kinds of scrubs, you'll have to put a big white bunny suit over top of those because you're going into a sterile OR environment if you're going for a C-section. If it's a vaginal delivery, none of that applies. And the NICU will cover 4 deliveries, generally for the whole day, aside from 1 to 5 p.m. when our friends in the general care nursery take over coverage. In the morning, typically rounds start around 8:30 to 8:45 and can last for several hours, usually done by 11, no later than lunch usually. And then we use the afternoon for writing notes. We update families. If they're not there in person, we call, and that can be another really great thing that medical students can get involved with. And then just responding to any problems as they arise in the afternoon. So next I wanted to cover a couple of slides that involve what I think is high yield knowledge in the NICU. And as you can see, a lot of this is math. So I'm just gonna go through each of these problems. I think there's a total of 5. So starting with the first, this baby is PO ad lib, is what that means. So we're just letting the baby eat as much as they want when they want. And in the last 24 hours, they've taken 368 cc's of SIM-20. Their weight is 3.5 kilos. How many cc's per kilo per day have they taken? So to get to that answer, you just simply take the total daily volume divided by the baby's weight to arrive at an answer of 105 cc's per kilo per day. Then moving on to the second problem, how many kcals per kilo is baby receiving if they're on NeoSure 22 formula? and they've taken 28 cc's, either PO or NG, Q3 hours. I realize there's a lot of abbreviations and things in here. I wanted to pause for a moment to cover a couple of things. So just wanted to throw in a different kind of formula just to make the point that there are different types of formulas with different caloric content. So a regular baby formula that you'll buy in the grocery store is like a Sim 20 kcal per ounce. But a lot of times premature babies are on more calorie-rich formulas like this NeoSure 22 kcal per ounce. And then when we say PONG, that means we're letting the baby feed by mouth, and then they also have an NG tube, and whatever they do not take by mouth, we give to them via the NG. And so to get back to our problem, we've also been supplied their weight, which is 2 kilograms. So when you're approaching this problem, the first thing to figure out is the total volume that baby is taking in a day. So if their feeds are 28 cc's and they're feeding 8 times a day, just multiply that to get 224. It's their total daily volume. And then converting from mLs to ounces, the conversion factor there is 29.5 mLs per ounce. If you want to make your math easier or be able to do it in your head more easily, you can just round up to 30, which is what I typically do. So that comes out to 7.6 ounces daily. And then to figure out the number of kcals that they're getting, you need to know the caloric content of the formula and multiply that by their ounces. So 22 times 7.6 ounces. So baby's getting 167 kcals daily. And then we're trying to figure out how many kcals per kilo. So simply divide that by the weight. And this baby is getting 83 kcals per kilo. When I'm doing math, for me, the easiest thing is just to look at the units and figure out what I need to do to make the units correct. So moving on to the third problem, this involves calculating total fluids. And this one is particularly high yield since you will probably be doing this for all of your babies unless they're totally PO ad lib. But most likely, the babies you'll be following, it will not be quite as complicated as this problem. I just wanted to show you a little bit of a more complicated one so you could see how it's done. So in order to calculate total fluids, you need to know all the lines the baby has and what's going through them. So this baby's getting dopamine infusion at 0.2 mLs per hour. They're getting maternal breast milk, or MBM, 3 mLs every 3 hours. And then they also have TPN, or total parenteral nutrition, running at 3.7 cc's per hour with intralipids at 0.38 mLs per hour. And their weight is 0.9 kilos. So I first start off by going through each of the drips or formula breast milk and figuring out what the total volume daily is for that. So with the dopamine at 0.2, you just simply multiply the per hour times 24 to get your daily volume. So you go through each of them and do that. Add all of those together to figure out the total volume that baby is getting every day from all their drips and everything. And we got 126.9 mLs per day. And then all you need to do is just divide that by the baby's weight, and you get total fluids of 141 mLs per kilo per day. And sometimes you'll hear us shorten that to just, you might hear us say something like 141 per kilo per day. And that's the same thing, we just shorten it to that. A couple more. So problem 4, this newborn weighs 2.5 kilos and urine in the last 24 hours has been 150 mLs. And so we're calculating urine output here. This is a nice little simpler one for a little break. So if their total urine has been 150 mLs, all you do is divide that by their weight to get 60 mLs per kilo, and then divide it again by 24 to get the per hour. Babies had 2.5 cc's per kilo per hour urine output. And then our last math problem for a little bit, number 5. You are taking care of, that stands for infant of a diabetic mother. D10W was started at 80 mLs per kilo per day, which gives a GIR or glucose infusion rate of 5.6 milligrams per kilo per minute. And I'll explain a little bit more what GIR means. The infant is still hypoglycemic, so you want to increase the glucose infusion rate by 2. What will the new IV fluid rate be? And their weight is 4.6 kilos. So the glucose infusion rate, I've included the formula of how you can calculate that. No, there are different ways to calculate GIR, but this just happens to be the one I like. And it's just a way for us to know the dextrose content of the fluid we're giving. And so I've included some formulas to show you how to calculate the IV rate that you need to do in order to obtain a particular GIR. So you just take the IV rate, will be equal to the GIR that you want, your goal GIR, times 6 times the weight. So do all of that, and then finally divide it by the percent dextrose. And don't turn that percent into a decimal point. So like for this problem, it's D10W. Don't divide by 0.1, divide by 10. And our goal GIR here is 7.6. So you can see how using this formula, I arrive at an IV fluid rate of 20.5 mLs per hour. This one is a little bit more advanced, but I think it might be helpful for you to look back on if you do happen to be taking care of an infant of a diabetic mother, just to understand a little bit better what we're doing with the fluids when we adjust these GIRs. Next, I wanted to switch gears to presenting in the NICU. And presenting here is different than probably anywhere else you've been as a medical student. And hopefully on your first day, like I said, we know it is a very different place. And so don't feel too bad about it if you feel like you struggle a little bit at first. I know I definitely did. So to start with your presentations, always start with this type of one-liner. You say, this is a 29-day-old former such and such weaker, now corrected to so many weeks. Follow up that statement with a summary of anything that happened overnight. And if nothing happened overnight, that's okay. Just say no acute events overnight. And then immediately you switch into a problem-based presentation. And in the NICU, we don't formally present the vital signs or the physical exam unless it is pertinent to the problem. And so when you're going through each of these problems, you'll talk about if there's anything that needs to be brought up in terms of physical exam or important lab findings that pertain to each of these problems, you bring it up in the context of the problem. And so the two problems, you always start with fluids and nutrition as your first problem. And when you're going through that, this is where you'll comment on things like the baby's total fluids, what exactly we're feeding baby from a nutrition standpoint, their weight change, their urine output. And then in your plan, you'll talk about if you want to advance their fluids or feedings in any way, and any vitamins they might be on, like vitamin D, iron, that kind of thing, will be in your plan to just continue those things. Then moving on to the second problem you always go to following that is the respiratory problem. But I don't want you to call it respiratory. Try to challenge yourself to think about what the disease process is in that baby and call it by that. So if this baby has TTN or transient tachypnea of the newborn, or if it's a BPD or bronchopulmonary dysplasia problem, then label it that, not just respiratory. So when you're presenting respiratory, this is a good time to talk about if there's any A's and B events or Apney-Brady events. Know what kind, if any, of respiratory support the baby is needing and how that's changed. If they're a baby who's getting blood gases, you would definitely include the blood gas values in presenting this problem. And then when you jump to the plan, you will talk about if you want to wean or increase their respiratory support, if you would like to get another blood gas at some point. These are all things that would be part of that plan. And then after you get through those two problems, you just go through all of the rest of the problems that the baby may or may not have in any order that makes sense to you. But just always start with fluids, nutrition first, then the respiratory problem, and then whatever else. The last problem or thing that we wrap up with is their healthcare maintenance. So thinking about things like, have they received their hepatitis B vaccine? Are they getting ready for their 2-month vaccines? Do we have consent from the parent for those things? Are they due for a screening head ultrasound? Those sorts of things go in the healthcare maintenance, along with if they might be due for a newborn genetic screen repeated. We do all these things really frequently in the NICU. And then when you're done getting through all of your problems, you'll finish up with this mnemonic fellow, which is kind of new to our NICU. We're trying to incorporate it. And there's a couple things that are going to be presented by the baby's nurse. So labs and orders the nurse will be presenting those for you. But you will start with F, any family updates, how you're changing their fluids. Then E, if they have an endotracheal tube, know the last time you got an x-ray, where that's taped at. And then L for lines, know if they have any central lines, how many days those have been in place, if they have a UV or UAC, the last time you got imaging of those lines, all that kind of information. And then the last one you'll be presenting is just, why am I still here? And so a brief statement on what that baby is still working on or needs to improve before they can be discharged home with their family. And it's okay when you're in the NICU. We don't expect you to be able to come up with some of these plans by yourself. Reach out, ask us for help. We love to help. There's also a lot of protocols under the clinical care guidelines that you can find to help you better understand what we're doing. Because if you don't see these protocols, sometimes it can just sort of seem like we're making this stuff up. But in most cases, a lot of what we're doing is being driven by some sort of protocol. And if you were only going to look at one of these protocols, I would take a look at our feeding protocol for infants less than 37 weeks. I put that red arrow beside it, just to help you understand how we advance feeds for these little babies. So that is the conclusion of everything I was going to talk about for the NICU. I want to switch gears here and talk some about the general care nursery, or GCN. So the GCN, you arrive at 7 o'clock and chart review. On your first day, I know when I was an intern in the GCN, I would just invite the medical students to watch me, what I would call gather numbers or collect numbers for a brand newborn baby. Just because all the different things that we're trying to find for the baby can be sort of hard to find in the chart, and you have to look at both the newborn's chart as well as the mom's chart. And so it's really just easiest, I think, to watch one of the residents or interns show you how to find all of this in the chart. It's a little confusing. And then the next thing I would do is I share my dot phrases with the medical students, and I have different H&P dot phrases, plan dot phrases, all sorts of good stuff. And the reason I do that is because the M3 H&Ps can actually be co-signed by the intern or senior, and we can use that as the official H&P. So the GCN is a really great place where medical students can be really helpful, because I know that sometimes the volume of babies we have in the GCN can get quite high. So any help you all can give us is really, really appreciated. And so after we're done gathering numbers on all of our new babies and chart checking our older babies, then we start with table rounding in the workroom with the attending. That will typically go until about 10 or 11. And then when we're done with that, sometimes the medical students will go and do the bedside rounding with the attendings on all of the babies while the residents stay in the workroom to work on discharges and things like that. This is a really intern-run service, so feel free to ask them if you have questions about the plan and stuff. They'll be doing a lot of the things in the GCN. And then a couple of tips for the GCN for starting off here is maybe take a look at the newborn discharge instructions that we send families home with. And this is just for families to know how to continue to take good care of their newborn at home, how to keep them alive. And I know for those of us, I'm not a parent, and it's helpful to read some of this stuff. I learned stuff reading over. So it might be good for you as well. And then a couple of questions to ask all new parents if you're going to see a newborn is, are you planning to breast or formula feed? And then do you have a pediatrician? So that's everything for orientation. Then moving on to some high yield knowledge for the general care nursery and just a little bit more math. This will be it for the math, I promise. I wanted to take a moment to talk about the I to T ratio. This stands for immature to total neutrophil ratio. For every CBC that you interpret in the GCN, calculate this number. And we care about it because if it's greater than or equal to 0.2, which is the cutoff we use, then it could indicate an infection for the newborn. So in order to calculate this, you take the total immature neutrophils, so all of the bands and the metas in the differential, and divide it by the total neutrophils, both mature and immature. And so I've included an example here, and you can see how I came up with that. And then next, I just wanted to give a little plug for Billy Tool. I'm not gonna get into how to use Billy Tool or how to interpret bilirubin levels, because I think that could be a whole nother 20-minute presentation in and of itself. But I just wanted to make you aware that there is a website called Billy Tool that we use all the time to help us figure out what to do with these bilirubin levels. And if you're going to take away one thing from the general care nursery, I think the most important thing to learn is about the different types of neonatal jaundice and how we measure these the bilirubin levels. So almost done with GCN, just wanted to talk about how to present here, because it's also probably different than anywhere you've been before. But unlike the NICU, it's really easy. And so I wanted to start off, I thought the easiest way to do this would just be to fill out one of these sheets we use on a fake baby that I made up. And so all of our babies, we have these printed off in the workroom. And when a new baby is born, we'll fill out a whole section like this for the baby, where we collect all of these different data points from the chart. And when you go to present this baby, you just simply read from box to box, left to right, top to bottom. So I'll go through presenting this new baby as I would if the attending had never heard about this baby before. So this is baby Smith. They were born on 8/25 at 1:40 a.m. at 38 and 2 weeks via a vaginal delivery, vertex position, no vacuum or forceps, and no maternal fever. Rupture of membranes was 5 hours, and APGARs were 8 and 9. Their birth weight was 3,400 grams, AGA, length was 49 centimeters, AGA, and head circumference was 34 centimeters, AGA. Mom's blood type is A positive, antibody negative. Baby is O positive, antibody negative. Mom's a 28-year-old, now G1P1001. She's RPR negative, HIV negative, GBS negative, rubella non-immune, Hep B negative, and GC chlamydia negative. Pertinent maternal history, she has a history of depression. Mom intends to breastfeed. Baby has had no stool or urine output as of yet. Physical exam significant for a nevus simplex between the brows and CDM over the sacrum, otherwise normal. We don't have any data at this point in time, and the family intends to follow with our Rush PCG clinic as their pediatrician. So that is how you present a new baby. And then I wanted to also take a moment to show you how we would present this baby on, say, day of life 2 after the attending has already heard about them, because it's even more simple and shorter. So in that case, I would say this is baby Smith. Weight today is down 6%, and I always just write the weight change right to the left of the name column. And then you just simply go through whatever is new or has changed. So I would say baby has now had urine and stool output. We obtained a bilirubin that was 5 at 24 hours of life, low intermediate risk with a light level of 11.7. Baby's on the low risk curve. This was obtained due to some jaundice overnight. We will repeat the bilirubin level routinely at 30 to 36 hours of life prior to discharge. And the maternal postpartum EPDS is still pending. We'll ensure mom gets a repeat MMR prior to discharge, given her rubella non-immune status. That has not yet been done. And then to go through our discharge checklist, the only thing done has been Hep B, so we still need to obtain the newborn screen, pulse ox, and hearing. And that is it. That's all there is to presenting a baby that the attending already knows about. These are just some of the high yield shelf topics that might be worthwhile to study while you're on these 2 rotations in the NICU and GCN. And then I wanted to skip ahead to some of the slides at the end. So just a moment. So this is our slide going through some general tips for while you're on pediatrics. We work with a lot of great child life specialists, and one of the things they will frequently tell us is try not to ask a permission from a child for something when it's not an actual choice they have. So if you need to listen with your stethoscope to a child, it doesn't make a lot of sense to ask, can I listen? It makes a lot more sense to ask, can I listen, do you want me to listen on the front or the back first? Because that's a choice they have. I know that can be really hard to remember, and we've all made the mistake before and kicked ourselves after we've said something like that, but just do your best, but it happens to all of us. And then second kind of general tip is the HEDS exam, or that's our special social history for adolescents. So their home life, education, activities, drugs, sexuality, suicidality, safety is the mnemonic there. Don't talk about any of that stuff during rounds because it should be private. And a lot of times the adolescent will share things with us like that in confidence. And the attendings understand that, and they know it's okay to save that part of the history for after rounds if something important came up. And then a lot of times students worry about waking up our patients, and that's okay. It's our job to examine them and make sure they're okay. They're in the hospital, so it's very appropriate to wake them up. Don't feel too bad about it. Try to use developmentally appropriate language when you're talking with them. And in that vein, try to tailor your review of systems for the age of the patient. So for example, you're not going to ask a 2-year-old if they have chest pain. That's not something most 2-year-olds would be able to vocalize or communicate with you. So questions for the review of systems for cardiac would be for the parent. Have you noticed any perioral cyanosis, pallor, swelling of their hands and feet? And then a few questions you might forget when you're collecting histories in pediatrics that you don't think about for adults so much is the birth history, how their development is going, and their diet. So if they're breast or formula fed, or if they have a G tube, we need to know exactly how they're fed. And then a couple other things. I like to keep a vital sign badge buddy on my card. I use it all the time. I think it's worth getting if you want to do pediatrics or even emergency medicine. But if not, maybe just having a handy screenshot on your phone that you can access easily. And then definitely if toys are around, like these little light spinners, they can be super helpful for your exams. And most of our neuro exams for kids are totally play-based. So that's another thing, like you can't do a formal neuro exam for, let's say, an 18-month-old in the same way that you would an adult. So a lot of that is going to be play-based in how they interact with toys. Then just to briefly talk about some of these resources here, we divided it between shelf prep and things that are actually more useful for in real life in practice. So I know everybody's using UWorld. I wanted to make a plug for AMBOSS. This isn't too expensive. It's a question bank that I liked a lot when I was a medical student, because my favorite way to study is looking at questions and just doing a ton of questions. And so this was helpful for me to have an additional Q bank, because I remember I got through all the Peds questions and it just wasn't quite enough. And AMBOSS has really nice learning cards, I think is what they call them, that can be super helpful. And then in real life, I put the logo for healthychildren.org. So this is the Academy of Pediatrics website for parents and providers. And anytime a parent has a question like, I don't know, how much milk should my 3-year-old be drinking? And you're like, I don't know, then Healthy Children will have a whole article on the topic in most cases. So that's a really great place for both you and parents to look when they have questions about things like that. And then for NEO and Peds in Review, these are 2 publications from the AAP that give really nice, fairly brief review articles about different topics. So let's say chest pain in children. They'll have a whole nice review article that kind of walks you through the different questions you should ask, studies you might want to consider in your differential. And those can be really helpful. And then the podcasts we included are really only for those folks who think they want to do pediatrics or are interested. The Crib Ciders and Ped Soup are both really great. And so that is all I have. We're looking forward to meeting you all, and please reach out if you have any questions. I think the other really important resource I'd like to include is just the residents. We love to help you all, and so don't hesitate if you have a question to ask. Thank you so much.